Hello, Trail Seeker, and welcome to another exciting episode of the Learn True Health podcast. Today's interview was a difficult one for me to both conduct and also to publish. This is the first interview that I have done with a strictly allopathic practitioner. If you're not familiar with the term allopath, it is describing what a quote unquote traditional doctor would look like in the modern world. Someone who has a prescription pad in one hand and their tool belt is largely pharmaceutical based. So if you've grown up in the modern world and you saw a medical doctor as your pediatrician growing up, or now if you see a medical doctor, you probably are seeing an allopath, which means they think their way in which they look at health and they look at the body is different from a holistic practitioner. It's a very different philosophy. Naturopaths, for example, tend to lean more towards holism. So they look at the body as a whole, all the symptoms as a whole. They look at what's going on and try to get to the root cause based on looking at everything as a whole. Not only your physical body, but also your lifestyle and your emotional state and your relationships. And they try to piece it all together and see what is you as a person as a whole, what's going on that's creating the underlying root cause. Now, when you see an allopath, they tend to fractionate the body. So you'll see an allopath for ear, nose, and throat is over here. Your chiropodist, your foot doctor's over here. Your skin doctor's over there. They're not talking to each other, even at the Mayo Clinic. And I've heard this from several people. They really expected a better experience at the Mayo Clinic than what they got. And what they ended up getting was just seeing a bunch of specialists that didn't really communicate well as a team. And so your skin problems and the problem you're having with the pain in your foot and the pain with the problem you're having with your vision and maybe the problem you're having with your liver or your digestion, all those things would be treated allopathically separately with different drugs to manage the symptoms, but often they overlook seeing the body as a whole. And so where allopathic medicine is wonderful and absolutely just so needed in today's world is emergency medicine. I definitely wouldn't want to go to naturopath if I had a broken arm, right? You want to go first to the emergency room if you get into a car crash or have a broken arm, because that's where they really shine. They really shine when it comes to emergency medicine, when it comes to most surgeries and some infections. That's where they shine. The difficulty is when you see an allopath only for chronic illness, they tend to not get to the root cause and then support the body's ability to heal itself because their tool base are drugs, right? So the reason why I want to just take a moment to describe this is today's interview, which is a really good interview, and I feel that the guest is a very fair guest, but I'd love for you to listen through my eyes a little bit. Listen to today's interview with a bit of an understanding that as you listen to him, you start to hear that his model of the world, the allopathic model of the world, he went to well over 8 years of higher education. I mean, he is by far one of the most educated guests I've had on the show. I mean, he teaches doctors, right? So he is just outstanding in his field. He's highly educated, incredibly intelligent, right? And I'm not putting him down at all. But I'd like you to hear that everyone has blind spots. And I'd like you to just understand as you listen, his tool belt is pharmaceutical medicine. His tool belt. These are the things that he relies on, the things that he understands. I'd love for you to go back, if you didn't listen to the previous episode I just published a few days ago, episode 247. I'd love for you to go back and listen to that one, even maybe before you listen to this one, because we discuss from a holistic standpoint, from a functional medicine standpoint, the different ways that we can diagnose and the different ways that we can support the body's ability to heal itself. And even the episode before that, episode 245, we discussed a bit about this. So the last few episodes, in fact, I'm thinking of different medical professionals that I've had on. We've been discussing how holistically we can support the gut, we can support the biome of the gut, we can support the digestion and the body's ability to have a wonderful, healthy digestion, healthy immune system, and assimilate nutrition and build a healthy tissue, right? So how can we do that holistically? So we're really supporting the body's ability to heal itself. Now, the patients that Dr. Satish Rao sees, they're incredibly sick. They're already very sick, and they've already been seeing allopathic doctors for many years. And unfortunately, because MDs, allopathic doctors, are not taught nutrition, they're not taught the science of how our food plays a very important role in building or destroying our health. And so these patients have not been educated on what to do. And they're being given drug after drug after drug. And one very, very crucial and interesting thing that Dr. Rao says, and it really blew my mind, and you'll hear me kind of almost gasp. I'm pretty shocked he says it. But that he's identified a new illness that is man-made. And he's seeing that this is occurring more and more and more. We're seeing man-made illnesses. And what I mean by man-made is it's lifestyle, but it's also drugs. Because we're overprescribing, for example, antibiotics, that this man-made overprescription of these drugs is leading to creating new illnesses that have never existed before. And so we talk a bit about that. So it's really interesting. What's also really interesting is that he himself is a very conventional doctor, and yet he is seen as an outsider by his community because he's trying to spread information about these new man-made illnesses that he has identified through all of the science that that he has at his disposal. And it's interesting to see that even someone so conventional as him is seen as an outsider from the mainstream medical system. And this is an example of how very, very, very slowly we will evolve medicine. Because if they're not even willing to look at the science of something new that happens, because they're so afraid of new and change, that when we bring up things that are new, it just gets completely shut down. This happened to a naturopath who I adore, Dr. Joel Wallach. He was at the time, this is about over 35 years ago, he was a research scientist and a veterinarian pathologist and working at Yerkes Primate Research Institute, and he discovered the cause of cystic fibrosis, the cause and cure. We could have 100% prevented cystic fibrosis from occurring in the last 35 years. If his findings had been published. He brought all of his findings. He had other pathologists confirm, blindly look at all the slides, not knowing what he had discovered, but he had them all confirm his findings, and then he wrote it up and he brought it to the Yerkes Primate Research Institute, and they fired him and blacklisted him from the research community because it wouldn't have made them money. Because what he discovered was that the deficiency of selenium in utero causes cystic fibrosis. And later he discovered that selenium deficiency also causes muscular dystrophy, both in humans and in animals. These diseases are called something else in animals, but in humans, you can absolutely prevent so many birth defects because they're actually related to nutrient deficiencies. And you don't think that we in modern, America or Canada or the UK or Australia or whatever country you're in, you just don't think that we're not going to experience deficiencies. That only happens in third world countries. Not true. If you're eating the standard American diet, your life is void of nutrients. I shared a picture the other day in our Learn True Health Facebook group of what 8 servings of fruits and vegetables look like. And for me, that looks like maybe half a day's worth of food. It's not that much, but for other people, that's maybe what they'd consume in a month. And so we just need to take a step back and look at, what role am I playing in my health every step of the way? Because people will wait until they're sick. They'll go through the drive-throughs and eat whatever they want, because that's, sort of how the meme is, right? This is the collective unconsciousness around us, is that it's okay to just shove in our face whatever makes us happy. And then we get sick and we go to a doctor, we don't know why, and they give us drugs, and they give us more drugs, and they give us more drugs, and we get some surgery, and then we get some more drugs. And we're living a very miserable life. And I know that's not you, though, because you're a Learn True Health listener. I absolutely know that your life looks a lot different. And it's sometimes lonely to be a salmon. It's lonely to swim upstream and go against the grain. And while everyone else is laughing at you while you're eating your salad and quinoa salad, and they're eating their burgers and fries. My mom used to say, because I asked once for a Nutella sandwich on Wonder White bread, on white Wonder bread, which, I'd never had before. I've actually still never had before. But I saw some kid in grade 7 eat one, and I came home kind of crying, miserable, going, why do I get Brussels sprouts and chicken breast in my lunchbox, and why can't I have a Nutella sandwich? And she said something along the lines of, well, when you're 30, that kid's going to be in a wheelchair and you won't. And I just thought that was kind of a miserable answer. But now looking back, I really can appreciate the work my mom put into wanting to keep us healthy. And so looking at this, listening today to this interview, I just would like you to have those filters on, to listen for his experience as a doctor. These are the tools he's been given. And what he really does want to help people, but he has no education around nutrition and very little education around diet, but he tries. And he also is very defeated in a sense that he feels that no patient would want to even hear about diet, or how what they could do in their lifestyle, what they could possibly change. So it's just a very interesting dynamic. So I really hope that you take away some really interesting perspectives from today's interview. But just know that whatever his answers are, there's so many more answers out there. There's so many more answers out there in the holistic realm, that no matter what your condition is, I mean, he says in some cases he would have patients on antibiotics and antifungals for the rest of their life. And he has currently thousands of patients in which he is prescribing these drugs over and over and over again, because this is his tool belt. And I'm not here to judge him and say that this is absolutely wrong and there's only one right way and it's holistic medicine. But what I am saying is that there are more tools out there, and there's certainly got to be better ways than just being on pharmaceutical drugs for the rest of your life. But definitely, I know he does want to help people, and he is constantly looking to learn and grow and expand. So take in this information, knowing that with a grain of salt, knowing that there's so much more information out there. And also take in this incredible understanding that he himself, as a medical doctor, is admitting that we, with our lifestyle, with the big food industry that's advertising and pushing to us to eat, high fructose corn syrup and eat all this garbage food, and the pharmaceutical-based medical system that's pushing drug after drug after drug, but those two juggernauts are creating new man-made illnesses that their bodies have never had that deal with before. And he admits to it, and it's very interesting, his entire discussion around that. So I also would like to thank 2 Patreon supporters that have been supporting the Learn True Health podcast, Kim Farquhar and Naomi Murphy. Thank you so much for being supporters of the Learn True Health podcast. I really appreciate every single Patreon supporter that has taken the time to go to Patreon. You can go to patreon.com/learntruehealth, or you can go to learntruehealth.com and click the button in the upper right that says Patreon. You can pledge any amount of money you'd like each month, $1, $5. You get some bonuses if you join at $5 a month level or the $25 a month level. There's even $100 a month level if you would like me to share your message, if you have a business, or if you have a message that you would like me to share to all of the listeners, you could join at that level. And you can be a Patreon supporter for 1 month, for as many months as you want, for 6 months, for a year. All your money goes towards creating these episodes. It really makes a big difference. So thank you so much for being a Patreon supporter. Thank you guys. And thank you so much for being a listener of the Learn True Health podcast and sharing it with your friends and family. I love that we're doing this episode, because I hope that it is like the Matrix for you. I hope it has that experience of pulling you out of the Matrix a bit and getting you to see this world. People are walking around thinking that MD pharmaceutical-based medicine is the only medicine, and it's such a small piece of the puzzle when it comes to supporting our body's ability to heal itself. But people are walking around thinking it's the only answer and that everything else is just total quackery, right? And it's just crazy, because, I mean, if you've listened to any other episodes, you've heard holistic doctors and holistic experts help people to heal their body, totally come back from illnesses that the MDs have said they could never come back from. Even people who have had stage 4 cancer. I've had guests on the show that shared about people who've had stage 4 cancer who've gone into remission with natural medicine. So, it's not just one answer. Drugs are not just one answer. Pharmaceutical drugs are not just one answer. It's a very small answer. There's so many more answers out there. Thank you so much for being a listener. I'd love to hear back from you after you hear this episode. Please join our Facebook group, learntruehealth.com/group, or just go to Facebook and search Learn True Health. Join the Facebook group. I'd really like to hear what you thought about this episode and what you learned from it. I think that'd be a great discussion for us as a community to have. Thank you so much, and enjoy today's show. Welcome to the Learn True Health podcast. I'm your host, Ashley James. This is episode 278. Very exciting. Today we have an amazing guest on. I'm so impressed by his level of expertise. Dr. Satish Rao is a professor, is a PhD, is a very well-experienced doctor. And we're going to get into his bio in a minute, but what I'm really excited about is he's here today to teach us about something I have never heard of before, which is small intestinal fungal overgrowth, SIFO, and small intestinal bacterial overgrowth. Now, I've heard of SIBO before, small intestinal bacterial overgrowth, but small intestinal fungal overgrowth, I've never heard of before. And because today's guest is so well-researched and has so much clinical experience, he's going to be able to shed light on these digestive disorders that many people suffer from and don't know they're suffering from it. Dr. Satish, welcome to the show.
Thank you very much, Ashley. It's a pleasure to be on your show.
I'm really excited for you to teach us today, because looking at your bio, my jaw was on the floor. I just can't believe how much amazing experience you have working with patients, getting really specific in terms of helping them recover their gut health. I'd love for you to start by sharing your story. What motivated you? What led you to become a medical doctor that wanted to get into specifically working with cleaning up the digestion and helping, in gastroenterology and hepology, and getting into helping people recover their digestive health?
You really don't want to know, but now that you've asked, I think I'm going to answer the way it started. I come from a family of physicians, and my father is a professor of medicine and was the dean of the university. As I was growing up, maybe I was 7, 8, 9, he carried a pen with a white dot on it. That's the Schaefer pen. If you know the Schaefer pen, it has a trademark of a white dot. And whenever I would ask him, I want to have that pen, he would say, only doctors can have this pen. So that was my motivation to become a doctor. But more true than thereafter, I think I did enter medical school, and then he did give me his Schaefer pen, so which is, I still have that as a prized possession. But thereon, I did my medical schooling in India and then went to England to do my postgraduate training. And and that is where I really turned to learn about gastroenterology and particularly to focus on research and on a very important area of the gut called neurogastroenterology and motility, which was truly in its infancy in the 80s, early 80s and mid 80s. So I was mentored by two outstanding professors under whose tutelage I really started trying to understand more about the gut, gut muscles, gut nerves, how they work, how they don't work, and what happens inside the gut lumen, and when things don't go wrong or don't go right, what happens, and why do things go wrong. So that was my motivation to get into this field that we now called neurogastroenterology and motility. And I've been one of the pioneers in that field. Have been president of the American Neurogastroenterology Society about 5, 6, 7 years ago, and have had the opportunity really to learn so much, teach so much, mentor many, many people, and most importantly, help numerous patients with conditions that have generally been obscure and people have no idea what happened and why it hit them. And we've been able to understand a number of key disorders and dysfunctions in the gut and have found remedies to help them. And that's been my journey over the last 25 years.
Wonderful. Now, when you say remedies, looking beyond medicine, do you look into diet and lifestyle so that you can help the person gain their health back to the point where they no longer are dependent on medication?
I would love to, but that I think is one of the hardest things to do, particularly in America.
Because it's the
Having
food's so crappy?
no, well, not entirely food, it's just the people, I think. It is very interesting you asked that. I do see a change now in the last, I guess, 5 years or so. But, I've had the unique privilege of practicing in three different continents, not necessarily three different countries. I practiced a little bit in India, practiced in UK, and then, for 25 years or more in America. One of the hardest things that I've found in America is to change people's behaviors, cultures, their eating habits. And just to give you a contrasting example, every patient that I would see in India, I practiced for 3, 4 years, and that's about it. The last question they would ask me before they leave the door is, Doctor, what can I eat? Or what should I not eat? Now, turn back and come to US, I never get that question.
Really?
Or I'm exaggerating maybe, it's very rare that people ask. And even when I do advise them, it is very hard for people to change. I know you see a different kind of people and you meet a different kind of persons. People who are coming to you and to listen to your show and so on, they're very different people. They're very motivated. They have been burnt a little bit through the standard medical system. But if you go to the general patient, I think they are very reticent to changing things. So, answering your question in a circuitous way, I do believe that there are tremendous things that one can do to change their lifestyle, to change their behavior, and that can go a long way towards healing. But the important problem is it has to be done in tandem with other things that we can do as physicians and with prescription drugs and so on. It cannot be done without it. But in the long term, it is not the drugs that's going to really help them conquer their problem. It is probably their lifestyle issues that I think is what will give them long-term remedy.
Mm-hmm. It's good to hear that. It's sad that as a culture that those in America, and I'm going to say Canadians also, because I grew up in Canada, and I don't see a huge cultural difference, some cultural differences, but I think Canadians and Americans are similar in that they are not raised to see that their lifestyle is going to impact their health or their eating is going to impact their health, which seems ridiculous to me. And then India, which culturally they're so much more in touch with holistic healing, and I wonder, was the UK the same or similar? Did you see that those in the UK were more willing to look at lifestyle changes, or was India the one that was completely different from the UK and from the United States?
No, I think India is where people would ask the question. UK people don't ask the question. But what I found in Britain was the patients were very willing to institute changes, were very willing to take on recommendations and use them. Uh, in the US, it's been a little different experience. I don't think
Mm-hmm.
people really like to change. I mean, they may under some duress, but it is not going to come easy.
Mm-hmm. Well, we're up against it, but I'm glad that you see that in the last 5 years you've been seeing a difference. And I think that I just had a demographer on the show, and it's interesting to see that now the millennials, this millennial generation, right now is ages 14 to 33, is larger than the baby boomers. And so and of course significantly larger than the generation in between. uh they're the ones that are now kind of starting to have you're starting to see them, I'm sure, in your clinic with their digestive issues. And so what's interesting is the millennials have a different mindset, so hopefully they're going to shift and they're going to want to take more actions so that they can get their health back, so that they can eat a healthier way and find the lifestyle that's going to help resolve their issues. Let's get a little bit into understanding what is this thing called SIFO. Did you so this a small intestinal fungal overgrowth and small intestinal bacterial overgrowth? Um, who is having this? Is this something that we see in young people and older people? Is it people who've been on digestive aids or acid suppressors? What is this big problem that we're seeing, which is this, a chronic infection in the intestines, in the small intestines?
So I need to go back and talk about it because I've been intrigued by this for many years. I tend to see a very challenging group of patients from all over the country and also from internationally, and this has been my practice for very many years. As part of my practice, I would see patients with significant unexplained symptoms of bloating, gas, and pain, and so on and so forth. And to better understand and to characterize if there was indeed infection in their gut, I started uh, uh, aspirating fluid from the small bowel. We will normally do a procedure called endoscopy where we put a telescope down through the mouth into the gut and we look inside the stomach lining, the food pipe lining, and the small bowel lining. If we see something unusual, we'll take biopsies, or if we want to look for things like celiac disease and something, we will take biopsies. But as a routine part of this, in those selected patients, especially those that are undergoing further testing. For example, I place a tube with multiple pressure sensors inside their gut for 24 hours to study their gut motility, to see if their nerves and muscles are working or not working. So in those selected patients, I would also take juice from the small bowel to study if there is infection in their small bowel. And we take a sample of three cc's of juice. We send it to the microbiology lab to grow whether there are any bacteria or fungus. Now, we would find nothing grows in some people. In some people, we would get a rich growth of significant amount of bacteria. And in some people, we would find there's a growth of bacteria and fungus, and in some others, just fungus. So I've been seeing this since about mid 90s, and I would look at that, and appropriately I would treat the patient. If they get bacteria, we treat them with antibiotics. If I find fungus, I would treat them with fungus. Now, dialing further on by about 2005 or 6, we thought it was time that we really looked at this data that we had accrued of over 100 odd patients over many years and try to truly understand, is this all making sense? Then, when we looked at the data carefully, we found that about a quarter of these 100 odd patients had exclusive fungal overgrowth. A quarter had a mix of bacteria and fungus. Another quarter, or about 20%, had pure bacteria, and the remaining 30-40% had nothing. So that was the first time that we really more systematically looked at this. And then I tried to publish that work. And lo and behold, when you're ahead of the curve in the medical literature, you get frowned upon.
Mm-hmm.
So no journal would accept it. I tried 10 different journals. They would accept, they said, why don't you just publish your SIBO story? We believe that this bit of fungus you're growing here and there is just rubbish. And I said, no, it's not rubbish. It's true. I'm as hot-headed as the journals are. And yes, in about 2010, I did find a very reputable journal that was willing to publish it and publish it. And so for the very first time, the word small intestinal bacterial overgrowth and small intestinal fungal overgrowth was published as a major GI article. And since then, I think we have published another 3 or 4 other articles looking at the same thing and looking at various components of that. And we published a review about a couple of years ago in another well-known review journal that invited me to write a review talking about this in greater detail. So I think there is now a little bit more recognition that this is a true entity. The concern that people had, scientific community, was that maybe a little bit of fungus, is it really challenging? And it's not a little bit of fungus, is what I've tried to explain to them. When we grow, if there is a little bit of fungus, I totally ignore it. I'm never going to treat it either. But we define as a significant growth is they must have 1,000 colony forming fungi per ml of fluid or more. It's called 1,000 CFU or more. And some of them we grow 1 million or more, millions of more. So it is not that everybody is having 100 or 50 or 10. We don't even bother with them. Remember also, though, the area from which we are growing this. So the stomach is full of hydrochloric acid. It is one of the, God has really given us a very strong way of attacking and killing bacteria and fungus and everything with this highly acidic, very corrosive, appropriately corrosive environment. The duodenum is the tube that comes out of the stomach, and we are sampling within the first, let me say, 6 to 9 inches of the stomach. So it's an area that is continuously bathed by stomach acid. We're not getting it from the stomach, but we're really getting it from the beginning of the small bowel, which has a very high exposure to acidic environment. So in that area, there should be no bacteria. It should be relatively sterile. There should be no bacteria. There should be no fungus. But if we are growing bacteria and fungus from this area, there is a problem. There is a real problem. And this, I think the community is now slowly coming around to accepting this. Yes, there is some truth in what this Dr. Rao is talking about. And I think there is recognition that this is indeed a true entity. And again, we are taking the maximum possible precautions. When I culture, I demonstrate to my students and my mentees. They watch me do it. We wear sterile gloves. We try and make it as sterile. We can never be 100% sterile, but we try and make it as sterile as possible. And we grow it. And it's not that we grow it in everybody. We grow it in a proportion of people. As I said, about half of the patients we see, we grow either bacteria or fungus, not in everybody.
Right, you'd mentioned that the combination of the two, just over 60% of your patients ends up having either fungus, bacteria, or a combination of. And for you to have tested them, they came to you with symptoms of some kind of distress, gas, bloating. What other symptoms do people demonstrate that makes you want to go and perform this test?
So typically, the patients that we see in my practice, they're coming with unexplained abdominal pain, gas, bloating, fullness, belching, maybe some nausea or indigestion-like feeling. Those are the key symptoms that they come with. What is interesting is we also look very carefully in this group of patients, try to compare whether there is either one symptom or a cluster of 2 or 3 symptoms that can help us predict who has bacterial or who has fungal, SIBO or SIFO, compared to those who tested negative. Unfortunately, looking at symptom profiles, we are not able to distinguish who has this condition or not. Both those who have and who don't have very similar symptom profiles. So the only way to separate the wheat from the chaff here is really by doing the culture, and that is the way we can truly identify those who have an infection and we can treat, because symptoms seem to be very non-specific in this area.
When doing a health history and then doing an analysis of all the health histories, have you identified that there's a common factor that led to them creating this? Like they all at some point in the last 5 years were on antibiotics, or they were all at some point on antacids or proton pump inhibitors, or they all suffered from GERD or heartburn. Can you see a commonality that led to this?
That's a great question. I really like the question. I think that's where, as you mentioned at the beginning, some of the lifestyle and everything else comes into vogue. I'm going to just step aside for a moment and talk about what things we know medically, generally, that predispose patients to fungus infections in the body as a whole. These fungus infections can be in the mouth, it can be in the oral cavity, it can be on the skin, it can be in the vagina, and so on. And typically, people who have an underlying depressed immune system, let's say people who have cancer, lymphoma, leukemia, or HIV infection, these are, prime group of individuals who don't have the right immunity to ward off an infection from fungus. And fungus is naturally present on our skin. I mean, there are several types of fungi on our skin and in our mouth, and in some of the areas that are exposed to the environment. So it's normal for them to be there, and there is a healthy symbiotic relationship between the other bugs that are there and this fungus. But when something changes inside the body, like you have an infection, then the fungus can overgrow. Another situation is diabetes mellitus, or people who have taken steroids, or people who have taken antibiotics, or young children, or the elderly, particularly those who have been hospitalized. So these are general risk factors for fungus infection that we all know. But what is interesting and intriguing was when we tried to look at our own group of patients who were getting this fungal overgrowth, and the 2 factors that stood out. Number 1 was use of proton pump inhibitor. And number 2 was the presence of small intestinal dysmotility. So these 2 factors clearly increased the risk several fold of developing SIFO in our study. So what has happened over the years, as you know, I mean, PPIs have been used excessively and aggressively for management of sometimes very trivial symptoms of heartburn and reflux. It's fair enough, I think people have symptoms, and I give a lot of PPIs and we treat them. But then one has to be cognizant that they may not need it after a period of time, and they may need to be stepped down to less stronger agents, and that doesn't seem to happen. And consequently, people stay on this very strong, very powerful drugs. And as I mentioned earlier on, that acid is an important defense mechanism in the gut. And once you have knocked off the acid or you weakened the acid, then you have really exposed the gut to invasion and infection. And small intestinal dysmotility is the other factor, where the gut has a very interesting program of motility, particularly the upper gut. Every 90 minutes or so, as long as you remain fasting, there is a beautiful, strong, sweeping, like a tsunami, that literally goes through the gut. It starts somewhere in the stomach and sweeps its way through to the colon. It stops right at the beginning of the colon. This is called migrating motor complex, or MMC in short. Every 60 to 90 minutes, this happens in every healthy human individual. If this pattern does not happen or is disrupted, then you have a problem in your small bowel. Small bowel does no longer have the ability to clean its contents. This is called the intestinal housekeeper activity. So if you don't clean the house, everything accumulates, your dust, your mite, and everything. Just like that, bugs, fungus, everything accumulates in the gut. And then you get an overgrowth of bacteria or fungus. And that's what happens in this individual.
So you've listed some of the common things that you saw that led someone to have a fungal overgrowth or a bacterial overgrowth in their small intestines, depressed immune system, diabetes, being on steroids at some point, antibiotics, being hospitalized. Being in a hospital, you're probably likely to have also been put on antibiotics or a combination of drugs, or been exposed to bugs that you aren't normally exposed to. And the biggest one is the use of proton pump inhibitors, which or antacids, which is going to lower the stomach acid to the point where now our defenses are down, and so the acid isn't going to healthfully kill incoming bacteria and fungus, and it's going to allow it to enter the small intestine, which it's not really supposed to do. So are you seeing that the biggest problem is that people don't have a strong and healthy stomach acid, and that over time, being on medication, a combination of weak stomach acid, being on medication, which weakens it further, bringing down the defenses. Is that the biggest threat that is causing SIBO and SIFO?
I personally think so. I think this is unfortunately man-made, and I think that is I truly believe that has led to a significant increase. I mean, I've been practicing GI for 25, 30 years. I don't believe I've seen this many patients with these kind of symptoms for a long time. No question that we are recognizing it and we are diagnosing it, but nonetheless, we were never using these powerful drugs for this length of time.
I love that you said
That
man-made. That really hit me, because we're now seeing generations of people who, I mean, however long we've been here as humans, hundreds of thousands of years, only in the last 100 years have we been using, pharmaceutical medicine, and only really in the last 30 we've really been using the refined medicine that we see now. And we're having people on drugs that we've only watched one generation of people be on these drugs, like these new acid suppressors, proton pump inhibitors. We're seeing all kinds of new immunosuppressant drugs. Gastric issues are on the rise, whether it's a combination of our diet, our poor diet, our heavily stressful lifestyle, the fact that we haven't been taught, or as a society haven't been focusing on preventive medicine, whatever it is that's causing us to develop heartburn, and then we go to the doctor, we get put on these drugs, and now we're seeing man-made illnesses. And I think it's interesting that you said the word man-made, because that's why you are discovering an illness that you kind of got pushback from all the journals, because you're the finally the uncovering this issue, that it's like, yeah, if we don't look at the long-term consequences of these drugs, of all of our choices, we're not going to be able to recognize and treat these new issues that we've never seen before. So it's interesting that it's man-made. I know a lot of people with SIBO, and like I said it before, I've never heard of SIFO, and I bet some of them have it, and their doctors don't even know to look for it. So I'm really glad you're here today to shed light on this subject. That a lot they're taking medications, especially like you said, long term, comes with consequences. A lot of people stay on proton pump inhibitors for years when they're only supposed to be on it for a short period of time, and then try to then decrease and get it back under control. How do you treat SIFO and SIBO? And then, once you've helped them to kill off the overgrowth, what is it that you do to help the patient? Even though, like you said, most people are reluctant, but if you had a patient that wasn't reluctant, What kind of lifestyle changes do you help them to make?
So first is once we identify someone has SIFO, my goal is to try and eradicate it. And I typically give them a 3-week course of an antifungal therapy, usually with fluconazole, largely because I'm not convinced that nystatin that we can take orally really gets into the small bowel in adequate amounts to really be effective. I think it gets destroyed by stomach acid. So fluconazole, which gets absorbed into the bloodstream and then acts, is probably my drug of choice. It's fairly well tolerated. Or there are some other drugs called itraconazole that we can use, or ketoconazole that we can use for treatment. That I think is my first step. And in some, I have to give it cyclically and repeatedly, especially when I have to maintain people on recurrent course of antibiotics because they have underlying gut motility problems and they really need long-term treatment. But the other component of the treatment is really to get rid of any potential incriminating factors, like if they have diabetes, to get tighter on their diabetic control, if they're on steroids, to minimize steroid use. But if they have a motility problem, which is what I tend to see because of my subspecialty, I try and place them on drugs that can stimulate the motility. Unfortunately, we don't have very many good drugs, but we have maybe 3 or 4 drugs that are available, and I try to give those drugs in small amounts to try and speed up their motility. Also, really working very hard to get rid of PPIs from their treatment. I mean, luckily, because of my GI background, I can really find alternatives for them. I can find other ways by which we can manage the reflux disease. And so that is another component of this management. So getting rid of PPIs, improving their motility, initial good course of antifungal therapy to get rid of the fungus, and then maybe consider maintenance or intermittent courses if their symptoms relapse is usually what I do.
Now, I'm going to ask this just because I just had a doctor on that spoke about this, so I wonder if you've seen this as well. Have you experimented with like IV magnesium to stimulate the mobility? And have you seen that could be an alternative, a safe alternative to the drugs that you say you don't have many effective drugs for increasing mobility?
No, I have not used intravenous magnesium. It is not, it is good and it is not good. It does have some effects on gut motility, but generally magnesium tends to have more calming effect rather than a stimulant effect on gut motility. It's not my drug really for these patients. There are other drugs that we can use that can have some stronger immediate short-term effects. These are drugs called neostigmine group of drugs that can have a short stimulant effect if we want to. There are more side effects with those drugs. They have to be given in carefully monitored conditions, sometimes in ICU situations and so on. So if you ever have to do that, most of the time there are drugs that I give are oral that are slower in onset and hopefully safer. So that is the approach that I take.
Got it. Now, in terms of diet, while someone is under treatment for SIBO or SIFO, is there a way in which they should eat that doesn't help to feed the infection that they're looking to kill?
It has been an intriguing question for me. I do believe that diet has a role. I'm not sure what type of diet would be the best, and that I'm really still at a loss to really figure out. I think intuitively, maybe by giving more acidic containing food, probably we can because we do know that the fungus hates acidic environment, so we can actually kill off the fungal bacteria. So eating more acidic foods, but more acidic foods can also trigger reflux symptoms. So it is always it is very fine balance between the acidic containing foods and the alkaline containing foods, and really trying to get a balance, and also looking at individually folks are tolerant and intolerant of various food products. So what I tend to do in my practice is we have very important, simple, non-invasive breath tests that we do, not only to identify SIBO, but more importantly, to identify food intolerances. We have a breath test for fructose, which is the fruit sugar. We have a breath test for lactose, which is the milk sugar. We have a breath test for fructans. Fructans are the sugars that are present in wheat and onion and garlic and artichokes and asparagus and chicory and so on. So these are common food ingredients in our diet that unfortunately some folks have inability to digest or handle. And that in turn triggers a lot of symptoms such as gas and bloating and diarrhea and so on and so forth. So I have the ability to test them for these intolerances in our lab. So I use that information together with the presence of SIBO or SIFO, and then I usually send them to my dietitian. We also have our patients keep a 3-day food chart to look at their likes and dislikes. And then we come up with a formula diet, if you like, that would take into consideration their likes and dislikes, that takes into consideration their intolerances as we have defined it scientifically, and then that also takes into consideration a balanced nutrition need. And that is what I've generally used in practice. There has been no specific diet, but I'm intrigued, and I think there is clearly, I believe, room for formal testing of more acidic diets versus more alkaline diets, and seeing if they have a role in the long-term management of patients with SIFO. We have not formally tested that.
And one thing you had mentioned is when diabetes, you need to help people get their diabetes under control. And I believe the number is something roughly 1 in 3 people are diabetic or pre-diabetic. So it's a significant part of the population that has blood sugar that's moving towards being out of control. Is it that when people have high elevated blood sugar that feeds the infection, that feeds the fungus or the bacteria, and that's why it's best to help people get their blood sugar under control?
Absolutely. No question about it. I think, we all have developed sweet tooths and sweet tongues over the very many this generation, as you rightly said, the millennial generation is a classic example of this. And the industry has nicely contributed to this, particularly the American food industry and the American corn industry with the introduction of the high fructose corn syrup. It has been a disaster in my view. They have changed the entire way we eat and we drink. They have introduced so much of fructose that in 1966, only 16% of the food we consumed was fructose. Now roll forward to 2012, 66% of the food that we consume is fructose. I mean,
Oh
look
my
at the
gosh.
dramatic change in fructose consumption. And sucrose, which was about 58 or 60% in the 60s, is now down to about 18 or 20%. Sucrose is the natural sugar for which we have an enzyme called sucrase to break it down and digest it in the body. We do not have a good enzyme for breaking down fructose. We have very limited absorptive capacity for fructose. And we're challenging the gut with something that the gut was not programmed to have in the beginning. And so consequently, we're really creating a problem. And fructose, pure fructose, as it's now presented to the gut, unfortunately, is very harmful. We have limited absorptive capacity, and the more of it gets absorbed, it gets stored, it gets converted into fat tissue, it messes up the brain, it does a lot of things throughout the body. So the eating industry, the food industry, has unfortunately contributed to the way we do things, and I think we as the public have been taken for a ride. So it is sad, but that's what is happening. And I think if we can relearn to go back to eating natural foods as they exist. I mean, there's nothing wrong with eating fruits. Sucrose in fruit is fine, fructose in fruit is fine. But when you synthesize it and artificially change it, that's when things change.
I just saw something on Facebook today, a video or a news article of some kind that was talking about how there are schools, many schools in America that basically fired the lunch lady, and they hired McDonald's to cater the school lunches. And so these children are eating, the fried food and drinking the Coca-Cola. And can you just imagine the poor children, what between the fried food and the high fructose corn syrup in their drinks, what it's doing to their digestion, let alone their neurology, let alone, their developing bodies, their immune system. But like you said, the body cannot digest fructose in a way that is, healthy, like sucralose, and sucrose, sorry. And so you're just basically giving food to the bacteria and the fungus so that they can thrive. Also, really interesting about fructose is you said it messes up the brain. It actually is the only substance that we consume that doesn't turn off the hunger response. That's why you can drink a 2-liter bottle of Coke and still be hungry for those slices of pizza. But try to drink a 2-liter amount of milk. You'd probably drink 500 milliliters and want to put it down. But we can chug as much high fructose corn syrup as we want because it doesn't turn off the hunger response. And it messes with the brain, like this lights up the same parts of the brain as cocaine. So you're very right. We've drugged our bodies with sugar, with processed sugar, and now we're feeding the wrong bugs in our gut, basically. Speaking of gut bugs, what about dysbiosis or the microbiome? Where do you stand there, and do you work with your patients to reestablish healthy gut flora? Do you see that plays a role in their healing?
It does. It does. I think, we really need a healthy balance of microbiota. We have over 500 billion bacteria in the colon. We are just scratched the surface of this entire bacterial microbiota host interaction story. I think we're just at the beginning of this. We have a very long way to go to learn about this. We don't have the right tools yet that are easily available so that we can characterize individuals' microbiome and see, okay, if you're coming up with this set of symptoms, and you happen to have this ethnic background and you tend to eat this kind of food, this is how your microbiota is or should be expected to be. And if it isn't, then it tells us, oh, there is a significant deviation for your background or your phenotype. If that can be established, then I think that will set the stage for us to better understand what may be wrong in individuals who are presenting with GI symptoms. We are not quite there yet, but I think we are moving in that direction. So I do believe there is a clear role for dysbiosis in the genesis of symptoms in patients presenting with either gas or bloating or diarrhea or constipation and so on. But I think we are not quite there in our understanding. And consequently, we're also not quite there in our ability to change this. Now, people have been giving probiotics, people have been giving fecal transplants, and so on and so forth. Again, not very well tested. I do fecal transplants. I do give probiotics in selected conditions, but only in very, very selected people. Where for fecal transplant, for example, in patients with C. diff infections, and in probiotics in people who have really had a nasty diarrheal illness, and in whom I do know that their bacteria have been wiped out or significantly disturbed, to try and help restore them, I will do it.
Have you seen any patients who adapted a lifestyle where they ate and drank cultured and fermented foods? And did you see that helped them?
It has helped some, but it also hurt some. I mean, which is intriguing. I mean, another area that I have now been struggling, just like I struggled with the SIFO story about 10 years ago. I think an interesting phenomenon that we've been describing, which I don't think we should go in, given that we should our time constraints, is a scenario called brain fogginess. And I know I hate to get into that area, but this has been a very interesting journey for us in several patients, now over 80, 100 patients that I've now seen who have developed brain fogginess uh, as a consequence of probiotic usage. What has happened in these individuals, they probably have some underlying predisposing factor in the gut itself to begin with. But on top of it, when you take probiotics, the probiotics are all designed to work in the colon. And they very likely will do some good there, or they may not do any harm anyway. But if the probiotics by chance stop halfway in the small bowel, then you really have created a problem. You have now created SIBO, because who is to say which probiotic will not stop halfway? Nobody knows
Mm-hmm.
that. No one
Mm-hmm.
has done a single study to show that if you take probiotic X, 100% of it gets into the colon. No way. So if let's imagine a scenario where someone does not have a proper motility. Remember, I talked about the migrating motor complex. I talked about small bowel dysmotility. And let's say your gut is somehow compromised from a motility perspective. It doesn't work very well. In that individual, now you take high dose of probiotics. What's going to happen to that probiotics? A bulk of that is going to colonize your small bowel, and you're going to get SIBO. And you didn't know that. You thought probiotics was healthy. You took it to make yourself healthy, or your doctor gave it, assuming that you're going to be healthy because you've been having some GI symptoms. That is exactly the kind of patient that I've seen. We've identified SIBO in their small bowels. We've identified the connection between brain fogginess, which is caused by a metabolic syndrome. And the way we have to treat them is with high dose of antibiotics to get rid of the colonization in the small bowel, and then get on the road to recovery. So that's another story. We can talk about it another time. But there you go.
It's very interesting. You know, my physician who thought that my husband had SIBO, we did that test where he blew into the little tubes and sent it off. Um, and he was borderline. The test was sort of almost inconclusive because it was borderline. But at the time, she said, stop any cultured foods, any probiotics, because if you have SIBO, taking probiotics is potentially making it worse, for the exact reasons that you said. And so it's almost like you want to deposit the probiotics as a suppository, so to ensure that it doesn't have to accidentally stop and start making cultures in the small intestine. Um, is there can anyone develop these or these symptoms, these issues, or have you noticed that it's more in men or more in women or more in older people, or are you seeing children have this problem? Have you seen this basically in anyone, or is there a particular age range or ethnicity that you tend to see these issues in?
I tend to see more women than men, but roughly 2 to 1. But it happens in both men and women. I don't see children, so I can't tell you what happens in children. But I've seen men and women of all ages, as young as 20s to as old as 80s. So I think it's all ages seem to have this phenomenon. It's not an age-related phenomenon per se.
Mm-hmm.
If you have some of the predisposing things that has been mentioned, I think anybody is likely to get it.
And do you when someone, especially with the fungus, when they go through the treatment, are there concerns of them experiencing like overtoxicity from die off, like as the bacteria dies off inside them, or as the fungus dies off inside them, inside their body? Are they going to experience other issues because of the toxins left behind from the die off?
No, I don't think so. I think I've read some things like that. Seems to be on the internet more than that. We have an outstanding scavenging system in the body. I mean, really, and we have enormous capacity for scavenging, particularly in the liver and in the kidneys and so on. And our capacity is enormous. So there is no amount of toxin destruction, antibiotic destruction that we can do that will overwhelm that capacity. And that is very, very unlikely. So I don't think that phenomenon truly exists. It's very much a myth, I think. So we have great capacity to handle that.
Got it. And since you've done a lot of work, looking at the small intestines, going down and taking a look at it and seeing what's going on there, have you seen a percentage of our population that also have parasites? Is parasites something that you've seen and have needed to also treat? I know there's been a controversy around what percentage of our population has parasites, either from traveling or from eating sushi or that kind of thing. Is that ever been a concern for you?
Well, I have seen. I mean, it's very rare, because I do a lot of endoscopy and I've done it for many years. In my entire career, I've seen about 4 or 5 patients, and that's about it. I've done over 50,000 endoscopies. So it is extremely rare to find creepy crawlies in the gut, so to say. Most of the time, of course, we're not seeing them. They are in. So it's very hard to truly pick up the parasites, even parasites such as Giardia and amoeba. I think quite often we pick it up really through either aspirates and cultures. That's the way we usually pick it up, and then we will treat them. But it's very rare to actually see them crawling in the gut itself.
Got it. So it's more likely that you could see it in a test because they're hiding somewhere.
Correct,
But
correct,
it
correct.
sounds like what percentage of your patients have a parasitic infection when you do that testing versus SIBO or SIFO?
Oh, the majority have SIBO or SIFO. It's a very tiny proportion. Remember, I mean, this is America, right? I think if I probably practice in India, I probably will see a lot more people, particularly from the rural areas. I would see a lot more parasitic infection. Occasionally, I would see people here, people who have somehow they've swam in some lakes that they are not used to, and so on and so forth. But it is not very common. It's extremely rare that I come across parasites here.
Very interesting. Well, it sounds like a lot of people are walking around with SIBO or SIFO, especially if they've had those other factors, which are really common, like out of control diabetes, have been on antibiotics or steroids, depressed immune system, have been on proton pump inhibitors. That is such a large percentage of the unfortunately, of the population. So it sounds like a lot of people are walking around with these issues and not knowing that their gas and bloating and belching and pain is being caused by the either the fungal overgrowth or the bacterial overgrowth in their small intestines. You seem to be really at the forefront of this, a pioneer. So thank you for coming on the show and shedding light on this subject. I imagine that the reason why you see more women than men is because more women choose to go to their doctor than men do, or the men that go to their doctor are forced by their wives. Um,
I don't know that, but I think irrespective, I'm very happy really to help them. I mean that really is very important from
mm-hmm,
our perspective. One other group I forgot to mention really are people who have had surgery in the gut, particularly colon surgery.
mm-hmm.
People who have had colon removed, uh, especially, and their ends have been joined, the small bowel has been joined to the colon. Um, that is a classic setup now for SIBO because you have now disrupted the normal barrier between the small bowel and the large bowel, the ileocecal
Mm.
valve. There's no longer a valve. There's a big gaping hole connecting the small bowel and the large bowel. And there must have been good reasons for doing that surgery. Whatever, I'm not disputing the reasons or the surgery, but unfortunately, that group of individuals are highly, highly susceptible and prone for SIBO and SIFO. That has not been recognized by the population at large or even by physicians. Many of these folks get admitted to the hospital, they get bloated, they feel pregnant, nobody knows. Someone may accidentally slap some course of antibiotics on them, but they continue to suffer. So that's another group of individuals. Again, a paper from our group will be published, I'm hoping, in the next 3 4 months, for the first time showing that people with colectomy have almost threefold higher incidence of developing SIBO when compared to those who don't have colectomy. So that would be another important area that I think would be worth highlighting to your public.
And that problem, it sounds like that would be the only one that would be the only demographic that would be chronic. That would be for the rest of their life. They would need to manage that reoccurring issue since, like you said, the
Absolutely.
barrier is now removed. How would you, if you had a patient in front of you right now and and you had just helped them sort of get rid of the fungal and bacterial overgrowth in their small intestines, what advice would you give them to help them prevent it as much as possible moving forward in their life?
I think most of those patients that I see, they go on lifelong antibiotics,
Oh my
lifelong,
gosh.
lifelong antibiotics, because we have no other way of preventing it. But I don't necessarily treat them with large doses. I put them on very small maintenance doses. We pick on the easiest regime. Some people, they may take a week or 10 days and a holiday for 20 days, and then take on antibiotic number two for the next month for a week or 10 days. There are a few who really need continuously. And I probably have hundreds of patients across the country who are on continuous antibiotics because that's the only way that we can keep them functioning and leading a healthy, normal life. Otherwise, they become very sick. So, yes.
Is there a concern about long-term antibiotic use? Doesn't that lead to superbugs or lead to infections that are resistant to antibiotics?
I think there is a concern. There is definitely some of these people do become resistant to, I mean, they become very smart. They say, Dr. Rao, the antibiotic number one and two seems to work well. The third one that I take, that month I don't feel good. Then I know that they've become resistant. Or I may intermittently sample them to see if there is a new regime that we have to come up with. But most unfortunately, I have not seen in my group of patients who I maintain on the antibiotics getting C. diff and other infections. So I've been very lucky, or whatever, I'm going to touch wood here, so that we are able to monitor them carefully and really help them out. But we are keeping them on low doses, and then we are rotating them and really including in the regime, if possible, potential antibiotics that can even be helpful if they unfortunately get C. diff. So we're looking at these combinations very carefully to prevent any untoward problems in these individuals.
Got it. Well, thank you so much for shedding light on this. Is there anything else that we didn't cover that you'd like to let the listeners know about these issues today?
My main plea is for my patients and folks is, don't take a no for an answer. Go search for the right doctor. Take them the evidence that's already published in the literature if you can find the literature. Uh, Make them aware. Don't sound too threatening. Don't be too aggressive on the physicians just because sometimes they don't have time and they're not knowledgeable. Give them time to get exposed to this area of learning. They can always call me. They can call my team. We will always guide them if they have any questions. But this problem can be diagnosed anywhere in the world. Don't have to come necessarily to see me, but it can be if they have to. But it can be diagnosed. It should be recognized. It can be treated effectively, and people can get well. So that will be my message.
It's very interesting that, and I'm glad you say that. I think it's really important that we advocate for our care and we pick our team of physicians and healthcare providers, like we're doing job interviews. Don't just go with the first doctor that you see and then give up when you've told them your symptoms and they don't listen. That is so frustrating. We must, like you said, continue to seek and don't take no for an answer and try to educate, bring the information to your doctor, and if they still won't listen, continue to seek an expert that will listen. The doctor that discovered um that ulcers were caused by bacteria, no one would
Yeah,
listen to him. Sorry?
Barry Marshall.
Yes, no
Barry
one
Marshall.
no one would listen to him. And you're like Barry Marshall. No one would listen to him. And so he drank a big beaker full of bacteria. He took snapshots of his stomach before drank a big beaker of bacteria. A month later, he was feeling horrible. He took snapshots of his stomach and then he published it and he showed it everywhere. And he said, "Look, guys, I'm telling you, this is an infection. Ulcers are an infection. He and finally went on to win. Didn't he win a Nobel Prize in this
Yeah,
research?
Nobel Prize. He won the
Yeah.
Nobel Prize for medicine. Absolutely.
And no one would listen to him, and everyone said, "You're crazy, you're crazy." And he had to do an own experiment on his body to prove it. And luckily, you didn't have to give yourself SIFO to prove it to everyone. Thank God you didn't have to do that.
Well, I don't know who's going to do my endoscopy and take it out from me, but I think maybe Barry did it, so I'm sure somebody could do it.
Right?
So
But
thank you.
luckily enough, people are now listening, and hopefully we can spread this information. But like you said, this is the reason why we didn't see it 50 years ago or 100 years ago, is that this is a man-made condition that our lifestyle choices as a society have created, based on the drugs or the food, that those combination of issues that have created it, like either being hospitalized or being on medications or having out of control blood sugar, consuming too much high fructose corn syrup, having a surgery. Any of these could create the perfect storm that allows us to create SIFO or SIBO. But it's a new problem that we're facing, and you're the pioneer that's saying, hey, we need to acknowledge the patient isn't crazy, or no, don't just give the patient something to make the bloating go away, make the gas go away, make the belching go away. Don't just give them drugs for that and then send them home. We got to continue doing further testing and take it seriously. So thank you for coming on the show today and exposing this information. It was a pleasure having you on, and good luck with all of the research that you're going to be publishing in the future.
Thank you, Ashley, and thank you for having me. And I hope we will talk some other time in the future for other interesting things.
I would love to have you back, especially want to talk about brain fog and the gut brain connection. That would be very interesting.
Will do. Will do. Take care.
Hello, True Health Seeker. I have a very exciting announcement. I have spent over a year, I've spent about 14 months collecting all of my information that I use with my clients for ending anxiety, and I created an online program. I'm very excited about it. We just launched it. And for you, for free, I have a webinar where I teach you 2 powerful mind tricks for removing anxiety, ending worry, and controlling fear so it stops controlling you and your life. In my free webinar, you will learn what causes anxiety and how to stop it, the science behind the mind-body connection, overcoming fear of public speaking, getting unstuck, ending that fear of things not working out, ending procrastination and overwhelm, and feeling excited, grounded, and calm instead of fear and worry. I have so much to teach you in my free webinar, and I'm really excited for you to come check it out. Go to freeyouranxiety.com/webinar. That's freeyouranxiety.com/webinar, or look in the show notes of today's podcast and you'll see the link there so you can jump into the webinar and learn all these wonderful, powerful tools that will end your anxiety and create excitement and happiness instead. Go to freeyouranxiety.com/webinar and sign up now, and I look forward to seeing you in the next live webinar. Hello, True Health Seeker. Have you ever thought about becoming a health coach? Do you love learning about nutrition and how we can shift our lifestyle and our diet so that we can gain optimal health and happiness and longevity? Do you love helping your friends and family to solve their health problems and to figure out what they can do to eat healthier? Are you interested in becoming someone who can grow their own business, support people in their success? Do you love helping people? You might be the perfect candidate to become a health coach. I highly recommend checking out the Institute for Integrative Nutrition. I just spent the last year in their health coaching certification program, and it really blew me away. It was so amazing. I learned over 100 dietary theories. I learned all about nutrition, but from a standpoint of how we can help people to shift their life and shift their lifestyle to gain true holistic health. I definitely recommend you check them out. You can Google Institute for Integrative Nutrition or IIN and give them a call, or you can go to learntruehealth.com/coach and you can receive a free module of their training to check it out and see if it's something that you'd be interested in. Be sure to mention my name, Ashley James, and the Learn to Health podcast, because I made a deal with them that they will give you the best price possible. I highly recommend checking it out. It really changed my life to be in their program, and I'm such a big advocate that I wanted to spread this information. We need more health coaches. In fact, health coaching is the largest growing career right now in the health field. So many health coaches are getting in and helping people, because you can work in chiropractic offices, doctors' offices, you can work in hospitals, you can work online through Skype and help people around the world. You can become an author. You can go into the school system and help your local schools shift their programs to help children be healthier. You can go into senior centers and help them to shift their diet and lifestyle to best support them in their success and their health goals. There's so many different available options for you when you become a certified health coach. So check out IIN, check out the Institute for Integrative Nutrition, mention my name, get the best deal, give them a call, and they'll give you lots of free information and help you to see if this is the right move for you. Classes are starting soon. The next round of classes are starting at the end of the month. So you're going to want to call them now and check it out. And if you know anyone in your life who would be an amazing coach, please tell them about it. Being a health coach is so rewarding, and you get to help so many people.